In this series of ECG Basics, today I will talk about Epsilon wave. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Friends, epsilon waves, these are small deflections, or we can say blip or wiggle, worried in the end of the QRS complexes. On the standard 12 lead ECG, they are best seen in the ST segment of V1 and V2, and they are usually present in lead V1 to V4. They are caused by the post-excitation of the myocytes in the right ventricle, and they are characteristics findings in patients with arrhythmogenic right ventricular dysplasia. In this ECG, we can see epsilon wave in V1 due to a right ventricular conduction delay. The epsilon waves are most specific and they are characteristics findings in arrhythmogenic right ventricular dysplasia. In arrhythmogenic right ventricular dysplasia, the myocytes they are replaced by fat, producing the islands of viable myocytes in a sea of fat, and this causes a delay in excitation of some of the myocytes of the right ventricle, producing a small blip seen during the ST segments of the ECG. Epsilon waves they have also been seen in patients with posterior myocardial infarction, right ventricular infarction, infiltrative diseases, and sarcoidosis. Here in these ECGs, the comparison of standard ECG versus Fontaine ECG, it is the ability to detect epsilon waves. The Fontaine ECG, which I will be discussing in my next slides, here the ECG leads are placed in a manner so that they enhances the ECG pattern and we can easily detect the epsilon wave. So the Fontaine lead placement increases the sensitivity of detecting the epsilon wave so that they are detected in the lead like F1, Fontaine 1, Fontaine 2 and Fontaine 3 rather than one lead in a regular placement. Just a brief about the history of epsilon wave. The guy Hugues Fontaine in 19 he was a French cardiologist and electrophysiologist. In 1977, he defined and named arrhythmogenic right ventricular dysplasia, the epsilon wave, and the Fontaine lead placement to best amplify the waves on the ECG. The term epsilon was nice because it occurs in the Greek alphabet after delta, and thus delta represents the pre-excitation and epsilon the post-excitation phenomena. And in addition, the epsilon is also used in mathematics to express a very small phenomena. Fontaine 1997. Fontaine bipolar leads they can be used to increase the sensitivity of the epsilon wave as I have already discussed, and the leads are placed as shown in the figures. Here the Fontaine bipolar precordial leads they can be used to increase the sensitivity of the epsilon wave. The right arm lead is placed over the manubrium, left arm lead is placed over the Xiphide process, and here in the picture you can see right arm lead is placed over the manubrium and left arm lead is placed over the Xiphide process, and the left leg in the standard V4 position, that is the fifth intercostal space in mid-clavicular line. Instead of regular leads like lead 1, 2 and 3, there are now three bipolar chest leads that are termed as F1, F2, and F3, which record the potential developed in the right ventricle from infundibulum to the diaphragm. The vertical bipolar leads F1 is similar to AVF. It magnifies the atrial potential and can be used to record epsilon wave, search for AV dissociation in the in the ventricular tachycardia, and to study the abnormal atrial rhythms when the P waves are too small on regular leads. A few words about arrhythmogenic right ventricular dysplasia. The ECG changes in arrhythmogenic right ventricular dysplasia, they include epsilon waves. These are most specific finding. They are seen in 50% of the patient, and T wave inversion is seen in V1 to V3, and these are T wave inversions are seen in 85% of the patient. Prolonged S wave upstroke of 55 milliseconds in V1 to V3 is seen in 95% of the patient, and localized QRS widening of 110 milliseconds in V1 to V3. Paroxysmal episodes of ventricular tachycardia with left bundle branch block morphology, that is RVOT tachycardia. These are the few criteria of arrhythmogenic right ventricular dysplasia. First is the epsilon wave, which is seen in 50% of the patient. T wave inversion in V1 to V3 seen in 85% of the patient. Prolonged S wave upstroke of 55 milliseconds in V1 to V3 seen in 95% of the patient. Localized QRS widening of the QRS more than 110 milliseconds in V1 to V3. Paroxysmal episodes of VT with LBB morphology. In this ECG, we can see that it is a suggestive of arrhythmogenic right ventricular dysplasia. Here we can see prolonged S wave upstroke. This is the ECG of a 32-year-old male who presented to emergency with palpitation, dizziness, and diaphoresis. Diaphoresis is excessive sweating. He had no complaints of chest pain or shortness of breath. The ECG on arrival showed sustained VT with left bundle branch block pattern. Heart rate was approximately 120 beats per minute and right superior QRS axis. Only a AVR lead with positive QRS complexes, and this atypical axis is a hallmark of VT with focus in apex of the right ventricle. So this child was, or this patient was cardioverted, and post cardioversion the ECG shows low voltage QRS complexes, epsilon waves in V2 and lead 2, and T wave inversion in all the precordial leads. It is difficult to see, sorry for that. This is the Fontaine ECG. Here the typical example of arrhythmogenic cardiomyopathy with left ventricular involvement. We can see epsilon wave as shown by the different arrows. This ECG shows VT, that is ventricular tachycardia with left bundle branch block morphology due to arrhythmogenic right ventricular dysplasia. As a caregiver, you see selfless act every day. With this, I conclude my today's topic. Thank you. Keep learning.